thank at first EHA Scientific Committee and EuroBloodNet for inviting me here today and for this second webinar about clonal eosinophilia. These are my conflict of interest. And as in the last webinar, I would like to start with a real clinical case of my institution about 50-year-old patients who came to our emergency room with leukocytosis, and in the morphological analysis of peripheral blood, we observed 40% of eosinophils. So on the chest CT, also a fracture of the third left rib. In the physical examination splenomegaly, we perform at first the BCR-ABL that resulted negative, and then we continue with the molecular analysis. And the molecular analysis revealed this time the rearrangements of FIP1-like-1 PDGF receptor alpha. So during the screening and for the molecular test, the patient started with hydroxyurea. And then since June 2016, started with the hematine for 100 milligrams for 1 month. But after the rapid control of white blood cell count since July 2016, continued with the hematine 100 milligrams per day. And after a few months, so in December 2016, the molecular analysis resulted completely negative. And currently, she continued with the hematine about the same dose in complete molecular remission. So the topic of today, according to the International Classification of Hypereosinophilic Syndrome, regard the tyrosine kinase gene fusion, so the so-called myeloid lymphoid neoplasm with eosinophilia and the tyrosine kinase gene fusion that should be addressed after the exclusion, immediately after the exclusion of secondary reason for eosinophilia. And if we look at the rearranged eosinophilia according to the last WHO classification, we talk about PDGF receptor alpha neoplasm, the more common form, but also we review together PDGF receptor beta, fibroblast growth factor receptor neoplasm, JAK2 rearrangements, FLT3, and those with ATV6ABL1. So the new findings reported in the last classifications are that they delete PCM1 JAK2 category that now is called JAK2 rearrangement because of the possible other partner genes together with JAK2, and mentioned also 3 new entities as you see in the table. So those with FLT3 rearrangement, those with ATV6ABL1, and not yet included, but we have to remember also very rare diseases with other tyrosine kinase gene fusions. So the common feature of all these neoplasms that originated from mutated pluripotent bone marrow stem cells that can differentiate into myeloid and lymphoid progenitors. And this explains the large heterogeneity of these neoplasms that are due all to a constitutive tyrosine kinase signaling as a result of a gene fusion. So frequently associated with eosinophilia in the peripheral blood and bone marrow, but not as an invariable feature. And some of them, in particular, PDGF receptor rearrangements, had excellent responses to specific tyrosine kinase inhibitors, but not all, unfortunately. And the broad range of histological types have been reported, most frequently observed as a chronic myeloid neoplasm or even as a MDS or mixed MDS-MPN, but also, unfortunately, as acute myeloid leukemia, mixed acute leukemias such as the MPAL, but also B or T acute lymphoblastic leukemia. And in most of these neoplasms, the extramedullary localization are common. And in some instances, in bone marrow, also atypical, usually interstitial, infiltrate of mast cells, but in the absence of c-KIT mutation. So the estimated incidence of all these neoplasms is less than 1 per 100,000 persons, very rarely observed in children. So this picture by Jason Gottlieb, I believe that well explained the heterogeneity of these forms that, as you see, may present as a chronic phase or chronic phase with extramedullary disease, or as a blast phase in the bone marrow, or blast phase with AMD, or as isolated extramedullary disease. The morphology is highly variable, and peripheral eosinophilia that was observed in all these neoplasm is most common observed in PDGF receptor alpha and ETV6ABL form. So the presentation is usually as a chronic myeloid neoplasm in the bone marrow, often with increased fibrosis, and in particular with dysplastic megakaryocyte, sometimes resembling MPN-like, so with abnormal segmentation, sometimes as MDS-like, so very small and hypolobated. So initially described in PDGF receptor alpha form, the atypical mast cells spindle around with aberrant CD25 expression, but usually not as in systemic mastocytosis. And indeed, a minority of patients may present as acute leukemia, but always with a underlying chronic myeloid neoplasm, so such as a blast crisis or most evident as patients post-chemotherapy. Extramedullary lesions are very frequently observed and usually involve lymph nodes or epidural and or paraspinal space. And these extramedullary lesions are B or T, acute lymphoblastic leukemia or lymphoma, but also as a myeloid sarcoma, a blast with a mixed phenotype, or rarely, but have been described as a major T-cell lymphoma, often with various eosinophilic infiltrates. And all these neoplasms may have somatic mutations observed in all the forms. For example, in PDGF receptor alpha neoplasm, somatic non-driver mutations have been reported in 20 to 50% of the cases, including also ASXL1, BCO, DN-methyltransferase 3A, ETV6, or even RANX1. But as you see, in all these neoplasms may be present all these type of mutation, but in particular, in fibroblast growth factor receptor rearrangement, the biological role of these cooperating mutations are still unknown, except for the evidence that around 80% of them involved RANX1. PDGF receptor alpha series, as you see in this table, several series reported, in particular with small series of patients described, but all agree that are very sensitive to imatinib, and after the achievement of PCR negativity, also to weekly imatinib 100 milligram. So the annual incidence of this neoplasm has been estimated around 0.18 cases per million, usually due to cryptic interstitial deletion in chromosome 4 observed with Fisher or RT-PCR, and the most common partner genes is FIP1 like 1, together with PDGF receptor alpha fusion gene, but other partners have been reported, and the more common are KIF5B or ETV6 or BCR. So this neoplasm usually presented as a chronic myeloid neoplasm in the bone marrow with eosinophilia in more than 95% of the cases. So as a chronic neoplasm, but sometimes very rare as a cell loss, with also very common extramedullary involvement. As in the other neoplasm, for unknown reason, but here it's more evident, the male-female ratio is 17:1, and the median age at the occurrence is late 40. So extremely sensitive, this neoplasm, to low-dose imatinib. And some series of patients have been reported with a long-term follow-up, such as these 33 patients rearranged for FIP1 like 1 PDGF receptor alpha, reported with a median follow-up of 64 months. 97% of these patients achieved a complete molecular response in a faster time, so median time to response is only 3 months. And some of these patients, after the stable and sustained PCR negativity, tried to discontinue, introducing the concept of treatment-free remission, such as in the CML. But unfortunately, 50% of these patients relapse. So the molecular relapse-free survival in this first series of patients is 50% after 47 months from discontinuation. And again, a large series of 151 rearranged patients were reported by the French group, and 96% occurring in male patients with a very important peripheral eosinophilia. Most commonly observed the organ involvement in splenomegaly, skin, lung, and heart. 10-year overall survival reported as 84%. And in these patients also, vitamin B12 and tryptase level are usually elevated in 94% and 79% of the patients respectively. So in this series of patients, 46 patients discontinued. As you see that the relapse-free survival after a median of 10 months is 57%. So prognostic factors are associated with a successful discontinuation have been reported, such as in the CML, the time of imatinib initiation and the total time of treatment, the unique two that are correlated with a successful DFR. Another small series of patients who discontinued reported by the German group, 12, that discontinued after the achievement of a complete molecular response, and 4 patients relapsed. So after restarting imatinib, 3 regained immediately the complete molecular response. But as you see that the molecular relapse-free survival then decreased very faster, and at 24 months was 65%. And the same authors reported also a registry-based cohort, including some patients in blast phase. So the number of patients reported with FLIP1-like-1 PDGF receptor alpha is 78%. And they also described that in these patients, but more pronounced in ETV6-ABL1 patients, there's the monocytosis in the peripheral blood, 33% in PDGF receptor alpha neoplasm, and 85% in those with ATV6-ABL1. As you see that also some patients in blast phase have been described, and with FLIP1-like-1 PDGF receptor alpha, 13 as a primary and 4 as a secondary blast phase. But when we look at the overall survival of these patients classified according to the rearrangements, at 5 years, for FLIP1-like-1 PDGF receptor alpha rearrangements is 92%, as you see, very different from what reported for all the other, such as fibroblast growth factor receptor or JAK2 rearrangement. Even when we group it together, PDGF receptor alpha and beta together, we have a difference in terms of overall survival. And this difference remain also in blast phase. As you see that the median overall survival reported in blast phase of patients with PDGF receptor alpha of beta rearrangement is 17 years, as compared to 1.7 years for all the other. So patients who perform an allogeneic stem cell transplant, again, in chronic phase, the overall survival in the registry is 80%, 40% in patients who were transplanted in blast phase. But such as in the CML, the treatment with imatinib, some specific mutations have been reported that may cause resistance to this drug. The T674I, that is the gatekeeper mutation, such as in the CML, the T315I, and also the D842V, so are the more commonly reported. Both are sensitive to ponatinib. The last one is also reported in gastrointestinal stroma tumor treated with imatinib. And in this latter case, also avapritinib, that is the new TKI for mastocytosis, has been tested with important activity. And some confusion, I believe, again, such as in the first webinar about chronic eosinophilic leukemia, reported for the activity of other drugs, such as second-generation TKIs. In this case, some patients respond very well to nilotinib and were classified initially as a CELNOS, but all those that responding well have FLIP1-like-1 PDGF receptor alpha rearrangements. Remember that literature indeed showed that if the patients have mutations such as the T774I mutations, the answer to nilotinib is not observed, also to dasatinib or to other drugs. PDGF receptor beta rearrangements, so frequency overall is 20%. Again, the median age at the occurrence is late 40. Again, male predominance, but less pronounced as compared to PDGF receptor alpha. So male-female ratio is 2:1. Commonly presented as a chronic myeloid neoplasm that should be similar to chronic myelomonocytic leukemia with eosinophilia, but also observed in some cases of blast phase, so acute myeloid or lymphoid leukemia, very rarely as a possible long-term progression of angioimmunoblastic T-cell lymphoma. The organ involvement and extramedullary lesions are not observed very frequently, but monocytosis and splenomegaly are common. Again, excellent response to imatinib first line. So usually due to the balanced translocation between the chromosome 5 and 12, And the more common partner genes observed is ETV6, but the other one in order is CCD88C, the most reported in very recently series of patients. But very common are cryptic rearrangements, frequently occurring in partners different from ETV6, such as BCR or SAR3, so likely due to small deletion, inversion, or other alteration with complex karyotypes. So has been suggested to detect these rare rearrangements with Fisher sequencing. And I believe that is one of the first articles that show the sensitivity to imatinib. Here, only 4 patients were treated with this drug, but as you see, with a very dramatic resolution also of extramedullary localization. Then this series of patients was updated, and 12 patients were old with the translocation 512 treated with imatinib was reported. The most common partners is ETV6, and 10 out of 12, after a median follow-up of 47 months, achieved a complete molecular response. And also we have this other series of patients published in 2014 that reported a very long-term follow-up. So 26 patients, all treated with imatinib, 18 with ETV6 as a partner gene. So the median follow-up is 10 years, and the overall survival at 10 years is 90%, with 36% described the molecular response. But none of the patients who achieved a complete cytogenetic or a complete molecular response then progressed to a blast phase. And another series was reported in 2017 of 22 patients with 15 different partner genes. As you see, again, the more common is in 23% ETV6. And this series showed also that 20% of these patients had no eosinophilia at baseline. With imatinib, all achieved a control of white blood cell, so a complete hematologic response, and a complete molecular response was achieved indeed in 86% of the patients after a median time of 19 months. Some patients presented also as a blast phase, and the overall survival is very low, as you see, as compared to the chronic phase, as some patients relapsed also after allogeneic stem cell transplant. So overall, in chronic phase, the 5-year overall survival is 83%, as in the PDGF receptor alpha rearrangements. Also in beta, the maintenance with low-dose imatinib has been suggested. Fibroblast growth factor receptor positive myeloid lymphoid neoplasm. About 16 different partner genes identified, but the most common is due to the balanced translocation A13, and the most common partner genes is ZMYM2. So again, the median age is late 30, again, male predominance, but 1.5 to 1, the male-female ratio. Eosinophilia has been detected, but a very, very strange neoplasm, because commonly presented together in the same patients, the chronic phase in the bone marrow, but together with different phases and lineage of the disease. So together with chronic neoplasm, also the localization of T or B, acute lymphoblastic leukemia, or mixed MPAL, or also lymphoma. Organ involvement is not frequent. Aggressive course as compared to the PDGF receptor alpha and beta rearrangement neoplasm, so without response to imatinib, and clinical and cytogenetic responses indeed have been reported to pemigatinib. So due to the trial that tested pemigatinib and that was approved in 2022 by FDA for this very rare neoplasm, the diagnostic criteria have been revised, and last year published on leukemia by Somali and colleagues. So they showed that the diagnosis should be performed with bone marrow involvement with a chronic neoplasm, or bone marrow involvement with blast phase, and or extramedullary involvement with a blast phase, and the presence of translocation A13, or each variant that includes the chromosome 8 translocation that leading to fibroblast growth factor rearrangement and myeloid cells, lymphoblast, or both. And these are the more common fusion gene in green, as you see, the more common. So the second one is BCR, but as you see, different partner genes have been identified, but fibroblast growth factor receptor rearrangement is located in chromosome 8p11. Ponatinib is not an elective drug in this neoplasm. A very small series of patients was reported, 7. Again, very heterogeneous in the presentation. Only 3 had the translocation A13 because bone marrow biopsy showed myeloproliferative neoplasm in all patients, but 5 presented concomitantly with lymphoid blast phase of acute leukemia or other diseases. So the more common partner genes are ZM2 or BCR, and ponatinib allowed a temporarily partial hematologic response observed only in 6 out of 7 patients, but only 1 patient achieved at least a partial cytogenetic response. Another drug that was tested, but only 1 patient was reported, is futibatinib. That is a very potent fibroblast growth factor inhibitor. So was tested in a patient that had another very rare rearrangement, so PCM1 fibroblast growth factor receptor. So this drug allowed the dramatic resolution of eosinophilia within the first 7 days, but the complete disappearance of PCM1 fibroblast growth factor rearrangements only after 175 days of treatment. But the approved drug is pemigatinib after the results of the 5203 trial, which enrolled 34 patients, most of them except 5 heavily pretreated. So 5 were treatment naive and 3 have also received an allogeneic center transplant. So at the time of the last report, 18 patients are still ongoing. So according to the Central Review Committee that we referred before for the diagnostic criteria, but also investigated the response criteria in the same publication, if the patients had only a chronic phase, 13 patients, so without extramedullary disease, or the Central Review Committee showed that the clinical responses in terms of complete response, hematological response, are observed in 89% of the patients, but with the same percentage also cytogenetic response. In 13 patients with blast phase component, the complete hematologic response is 61%, 54% indeed in terms of complete cytogenetic response. And Hernandez Boluda and colleagues reported also 2 years ago the series of patients that underwent allogeneic stem transplant. So 22, again, heterogeneous series of patients because in the majority there's the translocation A13, but also in 7 cases A22, in other 2, the translocation 6-8. So all the translocation that involve the chromosome 8 at the same level of the breakpoint. And over a third of patients displayed a chronic MPN, but another third of patients showed also the association with concomitant lymphoma or acute leukemia. So the 5-year overall survival was 74%, but also with 23% of possible relapse. 2 patients in relapse were rescued, 1 by ponatinib and 1 by pemigatinib. JAK2 rearrangement in this type of neoplasm, the more common described as PCM1 JAK2 fusion gene that arising from the translocation 8-9, but JAK2 can be also rearranged with ETV6 or BCR. So if we perform NGS in this type of neoplasm, we can find somatic mutation very similar to those with PDGF receptor alpha of beta rearrangement, again with male predominance, with eosinophilia in the peripheral blood, but this time, and this is the characteristics, with dysplastic erythroid proliferation. So in patients who presented with a chronic phase, an indolent course has been suggested, but indeed a very poor outcome in patients that presented as a blast phase. And we have very few reports about case reports with treatment with ruxolitinib. Ruxolitinib may act in these patients, but unfortunately, we showed limited responses, so limited benefits have been reported. A series of 66 patients was reported in 2022. Again, male predominance and very heterogeneous presentation in 40 patients as MPN, and the 5-year overall survival is 63%, in 21 as acute leukemia, with only 15 months of overall survival in myeloid form and 40% indeed in lymphoid form, and some patients, also 5, with T-cell cutaneous patient, the overall survival is 100%. Very few patients in this series treated with ruxolitinib to draw final conclusion. So even if not statistically significant, there's a difference in terms of overall survival of patients who underwent allogeneic stem cell transplant. So 80% as compared to 51% of patients who did not. So the T-cell cutaneous lymphoma indeed survived at least 7 years. And very peculiar last year, a single case report, but with the review of literature was indeed reported on hematological by Zhang and colleagues. So a patients with chronic bone marrow neoplasm, but with a extramedullary localization as a erythroid blast phase in patients with RUNX1 mutated. So the erythroid blast phase has been also reported in other two patients, again in lymph nodes, and in the third patient in the right ileopsoas muscle. FLT3 rearrangements, about 30 cases described, again with male predominance. So the median age at presentation is late 40. This type of rearrangements are largely detectable by cytogenetics because occurred at the level of chromosome 13, Q12, but can be also cryptic. Again, bone marrow with eosinophilia, but also as a MDN MPS similar to CMML or similar to atypical CML, but with eosinophilia that, as you know, indeed is a criteria of diagnosis, the absence of eosinophilia by ICC, but also with extramedullary localization that are quite common. So commonly indeed presented also as a T acute lymphoblastic leukemia or cell loss. So very heterogeneous presentation. Again, such an in fibroblast growth factor receptor, this type of neoplasm had a very aggressive clinical course. So allogeneic transplant are strongly suggested. And a series of 12 patients was reported by Tang in 2021. As you see, the first 6 with ETV6 as a partner genes, and a very heterogeneous bone marrow diagnosis have been indeed suggested. So some patients with normal bone marrow, but with extramedullary lesion. Some patients indeed in which an MPN unclassifiable or chronic myelomonocytic leukemia has been diagnosed, or even as a myelodysplastic syndrome without extramedullary lesion. So 67% presented peripheral eosinophilia, and 50% of this patient presented somatic non-driver mutation, very similar to PDGF receptor alpha and beta, or also with JAK2 rearrangements. And in the same article, Tang and colleagues reviewed also all the literature about all the other case reports with FLT3 rearrangement reported, in which a diagnosis of MPN or myelolymphoid neoplasm with eosinophilia has been indeed observed. In patient treated with tyrosine kinase inhibitor specific for FLT3, such as sunitinib or sorafenib, 6 were reported and 3 remain alive in complete remission. ETV6 ABL1 rearrangement. So ABL1, as you know, is located on chromosome 9 and encodes for a tyrosine kinase protein that plays a very important role in cell proliferation and the regulation of apoptosis, such as in CML. Again, male predominance, median age late 40. ETV6 ABL1 has been reported in MPN, but also again in acute phase lymphoid or myeloid. More commonly was observed eosinophilia in the peripheral blood. So 13 partners have been described, but most of them are produced by insertion of ABL in ATV6 or ATV6 in ABL1. So the morphology is similar to CML, sometimes with possible blast crisis. And again, a series of 44 patients have been reported, 13 in children, and most of these patients presented acute lymphoblastic leukemia. 22 indeed as a myeloid malignancies, in which is very more common in adulthood and not in childhood. So 18 as a myeloproliferative neoplasm and 4 as a AML. So in patients with acute lymphoblastic leukemia are more commonly observed as a BCR-able pH-like, with also ICAROS deletion or concurrent cyclin mutation. Unfortunately, over 60% of these patients described died, irrespectively of the disease or age subgroup examined. So very, very aggressive course, even in this subset of patients. And at least I would like to remember some rearrangements not yet included in the WHO, but the WHO suggested, such as 3 with ETV6 rearrangements, the first one with fibroblast growth factor receptor 2, with LIN, that I remember you is a SRC kinase, NTRK3, or BCR with RET. Some patients could be tested in case of eosinophilia in the peripheral blood, the bone marrow, because treatment with TKI could be absolutely feasible. So the take-home messages of this webinar are that all these neoplasms are very rare disorders, usually, as you see, for unknown reason, with male predominance, very heterogeneous presentation, so MPN or AML or acute lymphoblastic leukemia with or without extramedullary disease. Cytogenetic and molecular analysis are strongly suggested in case of eosinophilia, not due to a secondary reason for a specific diagnosis, even because some of these forms, even in blast phase, such as PDGF receptor alpha neoplasm, are extremely sensitive to TKI, in particular to imatinib. Some other, indeed, as you see, with FLT3, JAK2, or ETV6-ABL1, need intensive treatment and is strongly suggested in these patients, whenever possible, an allogeneic stem cell transplant. Thank you very much for your kind attention.
Thank you very much for your excellent and technical speech, and thank you for joining us once again. Is there anyone with any questions, for instance, for Professor? If now is the chance to put them in the chat, and then I'll read them out loud. While people are typing, I'd also like to just make a quick note about the upcoming 4th webinar as part of this series. I'll put that in the chat as well. And that'll be on June 3rd with Professor Florence Roufosse, which is titled Practical Approach to the Patient with Persistent Unexplained Hypereosinophilic, provided by Professor Florence Roufosse once again. Ideally, while people are typing their questions, I'd also just like to thank the audience. It's great to see such a high turnout as well. So we have a question here. Do you test a specific and limited series of cytogenetic rearrangements, and or do you perform NGS on all cases? Thank you, Professor.
So it's a question by Florence. At first, we start with PDGF receptor alpha because it's more common, but then in the panel, we include now beta, fibroblast growth factor receptor, and all these neoplasms that are suggested by the WHO. So in case of negativity, but if we have a clinic very suggested suggesting that the possible chronic myeloid neoplasm or even acute leukemia, so an NGS, I believe that is suggested. Absolutely.
Thank you for your question and thank you for your answer. Are there any other questions out there? If so, now is a great time to enter it into the chat. I have a special thank you.
You're welcome.
Perhaps we'll wait a couple minutes to see if there's anyone else typing.
Yeah. Yeah.
We also have another question here. We also hear about CHIP a lot these days. Are these mutations leading to eosinophilia highly pertinent? Not existent in CHIP cohorts? Existent?
CHIP mutations have been, I believe, identified in terms of NGS analysis in some patients in which this type of rearrangements are not observed with common sequencing or RT-PCR, or even in terms of cytogenetics. So we have only, I believe, to think about the possible results of these analyses, even because usually are exactly in terms of variant allele frequency that are very low as compared to somatic non-driver mutation that we observed together with this type of rearrangements, but with a high variant allele frequency. There's another question.
Okay, would you like to read this one, or it's another one from our fellow coordinator and expert?
Yes, it's another question by Florence. If all these type of neoplasm are corticosteroid resistance, like often observed for the FIP1 like 1 PDGF receptor alpha disease? Yes, absolutely. Are not the exact type of treatment has been suggested. Corticosteroids from all the literature, if the patient presented concomitant extramedullary involvement, and in particular the heart localization at first during the first period of TKI. But as you see that some of these are not sensitive to specific TKI and has been suggested only the allogeneic sensitive transplant. So probably to control the disease in the absence of other drugs, corticosteroids should be used.
I have another. Thank you. Any other questions from the audience? We have another question from Professor Roufosse. Are there any strong clinical associations with persistent hypereosinophilia for which you have a really high suspicion of clonal eosinophilia?
So usually associated with a persistent high level of eosinophilia, as you see in FIP1 like 1 PDGF receptor, so more than 1,500, but the clinics, I believe, here is completely different, and most of the time they have a very important organ involvement, in particular in the more common FIP1 like 1 PDGF receptor alpha neoplasm. So usually with leukocytosis and specific organ involvement, in particular splenomegaly, hepatomegaly, lung, paraspinal or epidural localization with some side effects reported of the localization. So we have always to think, I believe, to this type of neoplasm rearrangements at first to have a diagnosis of exclusion after reactive reason, but for reactive reason without, as you know, usually reactive reason are not associated with a specific organ involvement. So in case of organ involvement and in case of high level of eosinophilia in the peripheral blood, we have always to test at first PDGF receptor alpha, and then if we have the suspicion of clonal, the other form of rearrangements. Yeah.
No, thank you. Still plenty of time to ask any pertinent questions or any comments that you would like to share.
Yep.
Are there any racial difference in the occurrence of translocations?
Oh, wow. It's an important question. So usually observed without specific, I believe, racial differences reported in literature. So more commonly observed in white people, in particular the more common PDGF receptor alpha. But most of these articles referred also to Asiatic population, for example. So I believe that there is no specific epidemiological localization.
Great, thank you for the question and for the answer. once again, if there are any questions out there. Another thank you. And do you have any hypothesis why there is such heterogeneity?
If the heterogeneity is related to the presentation, because as I mentioned at first, the specific mutation occurred in early progenitors that are not differentiated into myeloid or lymphoid in lymphoid cells. So this explains the broad range of specific and very large manifestation of these neoplasms. So that are very complicated most of the time, also to be classified in the specific classification, I believe. So we have always to think, even when we diagnose, for example, an acute leukemia, but in the presence of the eosinophilia in the peripheral blood and in bone marrow with dysplastic megakaryocyte and an underlying chronic myeloid neoplasm, that should be referred to one of these specific subgroup of diseases.
Great, thank you. And perhaps one last question, or if not, even more. Thank you.
Okay. Is low-level translocation subclone clinical significant? So what does it mean? So if you refer it to NGS, you see the somatic non-driver mutation, I believe. The subclone is referred to a specific neoplasmoid eosinophilia is usually not a subclone. So we have an important clone associated with this disease. And Maki again replied that this about what maturation stage the translocation occurs. Probably yes. So you have an early progenitors not differentiated, and I believe that we have then, but is not specifically reported in literature, probably related also to the clonal architecture of all the other somatic mutation that should be associated with the specific, indeed, type of rearrangements that you have. The other one is, can any drug in treatment of T acute lymphoblastic leukemia cause eosinophilia and can confound this diagnosis? I really don't know if there's a drug that can be associated with eosinophilia, but yeah, I believe we talk about clonal eosinophilia and not related to other drugs. So I believe that is one of the reasons that we have to exclude at first of the diagnosis of TALL, not related to the drug treatment after for the specific leukemia, no? So if we have a case of TLL with eosinophilia, we have to test, I believe, at first that this type of rearrangements is not related to the drug after the treatment.
Great. It's always a pleasure to see the exchange between experts, healthcare professionals, and the
You're
level of
welcome.
expertise. Perhaps I'll ask one last time. Thank you, everyone, for all your participation and your engagement. Are there any last questions? Perhaps one last question? Multiple thank yous once again. Perfect. Well, at this point, I'd like to thank you once again for your presentation. It's a pleasure to have both professors, both coordinators here at the same time, and I hope that the turnout will be just as strong for the next webinar, number 4, happening on June 3rd. So we thank you once again for your participation, your expertise, and we look forward to seeing you in the near future.
Thank you.
Thank you once again, Professor. We appreciate it.
Thank you so much for your attention and your question. Thank you.
Thank you all.